let's take the case of a patient who has a full workup for their metastatic lung adenocarcinoma and has PD-L1 that comes back at 60% in the high range. We're happy with that. We haven't gotten the molecular testing back and thinking, well, we've got pembrolizumab or Keytruda to choose, then get ALK positive back from the molecular test. What would you recommend in this setting? I think to many of us it's kind of self-evident, but I think in the broader world it is not as clear to patients or general oncologists that when you have two potentially competing targets, how you would choose. Suki, can you start with your impressions of what you would do for high PD-L1 ALK positive?
Frontline.
Yes, frontline.
Yeah, so I think it's extremely important to wait for molecular testing. We know that PD-L1 testing comes back very fast because it's what we just call a protein-based immunohistochemistry test, which can be done very, very quickly. And we know that sort of molecular testing or gene testing can take time depending on what panel has been ordered. But, you know, I think it's critical because immunotherapy, as we've already alluded to earlier in this conversation, from what we know so far in ALK, immunotherapy on its own does not seem to be a very good option in terms of its ability to produce responses or control disease. And then the other issue is, right, if you start immunotherapy, the things that we have to think about now is once you remove the drug, that doesn't mean the immune system has all of a sudden become deactivated, right? The immunotherapy could have activated the immune system. And we know that there can be problematic toxicity issues when you combine with some of these targeted drugs, particularly with the ALK inhibitors as it relates to liver problems. So we have to think about that then. If we've already given a dose of immunotherapy and now you get the ALK result and are thinking about using a targeted approach.
And probably the worst choice of all would be to combine an ALK inhibitor
Correct.
and immunotherapy and think 100%. You're going to have double the benefit.
Oh, yes. Don't do that.
Jonathan.
I agree. I mean, initial PD-L1 high, you wait for the molecular testing, the ALK Alecensa, about an 80% response rate. Pembrolizumab, Keytruda, first line, approved for 50% or more, but they excluded EGFR and ALK patients. Mm-hmm. Response rate, I think about that scene in Animal House with Jim Belushi, or John Belushi, we ask his GPA 0.0. I mean, the response rate in that situation, you're looking at about 80% versus about 0 to 3%, maybe. It's a no-brainer, and actually get called about this from other oncologists not infrequently. And I think it's a major thing. And just to reiterate, just don't combine an EGFR, don't combine an EGFR and ALK inhibitor. I mean, EGFR and immunotherapy for ALK. Don't combine these, ALK inhibitor with immunotherapy. Yeah. It was published, by Dr. McCoach, who was here earlier. Crizotinib with IO, LFT abnormalities. IO also, as Dr. Padda points out, I mean, pembrolizumab remains bound to the receptor for about 3 months. These drugs have long half-lives. Right. Horrific toxicity combined with these TKIs. So
be very cautious. That's first line. Does the presence of high PD-L1 increase your receptivity or interest in immunotherapy as a later line, or not at all in patients with ALK positive non-small cell?
I don't think we know, but in general, from my practice, no. High PD-L1 in an ALK patient
doesn't mean the same thing.
Doesn't mean the same thing.
Completely agree.
Okay, so I think that's an important point, and I think that has been the general experience of the people who are seeing a disproportionate amount of people with ALK positive. Not as clear about EGFR. That may be the case, that high PD-L1 and EGFR mutation positive may or may not be. But I believe I've heard Dr. Heather Wakely, who, Suki, you work with, say that if anything, there seemed to be a disproportionate array of patients with ALK positive disease who have high PD-L1,
Yeah.
but it's a trick.
Mhm.
It doesn't mean the same thing, and we should be mindful that even if that doesn't mean never ever treat, which is a question, we shouldn't be too enthusiastic about it. Yeah.
Agree.
I mean, I talk, like I said, after I've exhausted multiple lines of therapy, we talk about combinations like the Empower 150. Or I say, well, let's see if, if exhausting everything else, do we have a nice clinical trial where maybe there's a drug in addition to the PD-1, PD-L1 drug in high PD-L1 expressing that can make that tumor more inflamed. That kind of makes sense. But I think that's way down the road. Try all the other lines of therapy, the ALK inhibitors first.